Hey, Marin Darcy, one of the neurointensivists. I frequently sort of get consulted in terms of patients in terms of helping with hypertension and AFib, and they are issues that we seem to deal with on a near daily basis. So you can certainly sort of potentially do harm with these sort of therapies, and so I thought it would be a nice thing to review. So just as a reminder, primary or essential hypertension is by far and away the most common type of hypertension. We're not yet sure of the identifiable cause, though it seems to have a genetic basis, and it tends to develop sort of in a progressive fashion over several years. When patients sort of are first diagnosed with hypertension, one of the first steps, and this is more of an outpatient thing, but is just sort of trying to understand if there are any associated comorbidities such as diabetes or hyperlipidemia, and then also sort of looking for any signs of end organ damage such as renal dysfunction, proteinuria, cardiac things like AFib, left ventricular hypertrophy, or ischemic heart disease. And in general, we typically don't look for any sort of underlying cause in that it's so common, it typically wouldn't be cost effective. There are sort of what we call secondary causes of hypertension, which are far less frequent than primary hypertension. And these causes obviously have an underlying cause, they're secondary. They are more likely to appear suddenly. Pardon me? I'm sorry, was someone saying something? Okay. Anyway, they tend to be far more severe and tend to be much more refractory in terms of these patients will typically be on at least 3, if not 4 or 5 or even 6 antihypertensives. You should consider a possible secondary hypertension in the setting of hypertension, especially that develops prior to puberty, but in general, hypertension that presents prior to the age 30, especially if the patient is not obese and there's no family history. If hypertension presents in the setting of hypokalemia or metabolic alkalosis, and then if it's refractory to multiple meds, and sleep adrenal issues, other endocrine issues, including thyroid problems, can cause it. One of the classic etiologies would be renal artery stenosis. Pregnancy is certainly a cause of secondary hypertension, whether it's pregnancy-induced hypertension or preeclampsia. Coarct of the aorta, sort of diet in terms of high sodium. And then numerous drugs can cause it, including basic things like OCPs, NSAIDs, and even, I was surprised to find this when I was sort of putting this together, daily Tylenol actually increases your risk of developing secondary hypertension. And this is just kind of going through it. Not surprisingly, other medications like chemo drugs, anabolic steroids, and some antidepressants can cause it. And so long-term sort of chronic hypertension, we certainly see some of these end organs damage in the context of our aneurysms, our ICHs, our strokes, and patients don't necessarily need to have symptoms leading up to these sort of catastrophic issues. And it certainly can cause problems throughout the entire body. So just sort of a quick overview of many of the blood pressure or cardioactive meds that we will frequently use in our neuroscience ICU. And let's just sort of hit some of the highlights of the different classes. So beta blockers, there are several different classes, and they're sort of broken into ones that are beta specific. Metoprolol is our most commonly used beta specific medication, and it's specifically known for its beta 1 effects. Sort of focusing in on the beta 1 is to some extent dose dependent. And because of this cardioselective beta activity, it's the preferred, it's one of the preferred beta blockers in the context of angina, myocardial infarction, and AFib. Whereas carvedilol, which we also frequently use because it has mixed beta 1, beta 2, and alpha 1 effects, it is more effective in terms of blood pressure control. And then we also use propranolol, particularly in our patients that have storming. Sort of one thing to sort of know about that, because it has non-selective beta 1 and beta 2, it's more cause bronchoconstriction, particularly in patients that have underlying asthma or COPD. So let's see here, Kelsey, if you were going to start someone on CoReg, what would sort of like, how would you sort of start them out on that medication, and what would sort of the things that you would be looking for in the coming sort of hours to days to understand if they're tolerating it?
So I think usually when we start CoReg, we start out at a pretty low dose. I think usually 6.25. You, in theory, could start even lower at like 3.125 or something. But I think usually we start with 6.25 twice daily. And then the biggest thing you're watching out for is to make sure they're not getting bradycardic in response to it. Or hypertensive, but I think bradycardia is kind of the bigger one that people don't tolerate it in terms of.
Yeah, and I a few months ago we had a case where an elderly woman, I want to say she was like late 80s, who was beta blocker naive. She got started at 12.5 milligrams of carvedilol and actually ended up in essentially she ended up with like beta blocker toxicity and needed to be like paced and had to get glucagon, and it was like a whole hot mess, that essentially it was just basically she started with too high of a dose. And so it's certainly one of those things where some of the themes that I'll be coming up again is this idea that it's really easy to add blood pressure medications, but it's really hard to sort of take them away. And many of these drugs, most of them, quite honestly, should be slowly up titrated. And I'm just trying to sort of focus on the things that you're sort of looking for to understand if you can continue to titrate. So obviously making sure that they're not hypotensive, but to your point exactly, bradycardia is important. One of the things that I sometimes will see is that we'll have a patient that has poorly controlled hypertension and they'll be on high doses of CoReg, and I'm like, okay, what's going on here? Do I need to add another medicine? But what will be happening is their CoReg will be at 25 or even 37.5 milligrams twice a day, but it's causing such bradycardia that the nurses aren't actually giving it. And so how you can probably better control their blood pressure is actually lower their dose of CoReg so that they're not so bradycardic that they're actually getting that medicine. And so sort of going that extra step and checking the MAR, talking to the nurse is important. Calcium channel blockers, typically when we're talking about blood pressure control, we're talking about the dihydropyridines, so the amlodipine, nifedipine, nicardipine, and in general, sort of in understanding which is sort of a preferable agent to use. So nicardipine is going to be an IV infusion. Amlodipine tends to be a one-time daily medication, and then nifedipine is typically sort of used in has a much quicker sort of time of onset and is metabolized more quickly, so it will be several times per day. In terms of starting amlodipine, things to know is that when you start the medicine, you may not actually clinically see its effects in terms of dropping blood pressure for 48 to up to 96 hours. So one sort of thing is it's reasonable to start at like 2.5 milligrams and each day sort of go up to like next day blood pressure still not controlled, go up to 5 milligrams, next day go up to 7.5, next day go up to 10, with the understanding that you may not have fully sort of seen the full effect until that 96-hour mark. Nifedipine, I think Josh tends to use it more than I do. It's a nice med. I think it probably is a little bit stronger and more efficacious in terms of controlling blood pressure. But medications that have like every 4 to every 6 hours need to be administered. They're not generally sort of successful meds in terms of patient compliance once they go home. And so things to know is nifedipine certainly has an extended release version, but it can't be given down a NG tube or a Daboff, though it can be administered through a PEG tube. So those are sort of patient-specific things to sort of keep in mind. Diltiazem, verapamil generally are more of a rate control medication, similar to sort of metoprolol, and so generally we don't use those in the context of high blood pressure. And things to know specifically about the calcium channel blockers, more for the DILT and verapamil, is really need to be careful using them in patients that either are post-MI or have CHF with a low EF. I generally don't use them when someone's ejection fraction drops below 45%, because you can sort of put them into acute decompensated heart failure. ACE inhibitors are another sort of great medication. We typically sort of use here for our formulary medications enalapril, lisinopril, captopril, or enalaprilat. Captopril is a nice medication when you're just starting a patient and you want to sort of rapidly up titrate. It can be given as frequently as every 8 hours. And so if you're worried that the patient might be getting a little bit septic, but they need better blood pressure control, but you don't want it to last a full 24 hours, captopril can be a nice medicine. And at each sort of subsequent 8-hour dose, you can potentially titrate up. Enalaprilat is a IV formulation of ACE inhibitors, and so frequently we'll have patients that'll be NPO for various reasons, and so that can be a nice option. And then lisinopril is probably our go-to. Just like beta blockers, ACE inhibitors are certainly medications that need to be thoughtfully up titrated, and in general, I try to avoid titrating them more than once every 24 hours. So Joyce, do you by chance know what like a good starting dose would be for lisinopril?
I'm not sure, but I've seen 5 milligrams.
Yeah, 2.5 or 5 would certainly be reasonable. If the patient had any underlying renal insufficiency or seemed like dehydrated, I would be more likely to start with that 2.5 range. And then things to sort of keep in mind is that ACE inhibitor induced angioedema is a big deal and can be potentially life-threatening and require intubation. So if you see a patient that has a swollen tongue or edema of their lips, or sort of difficulty swallowing that seems separate from their neurologic dysfunction, it's certainly something that you should keep in mind. And then one of the reasons that people will sometimes get switched from an ACE inhibitor to an ARB is this chronic dry cough that's associated with it. And then you can't use it in, we generally avoid sort of ACE inhibitors in women who are of childbearing age just due to the propensity to develop birth defects. And so ARBs, like we talked about, oftentimes will be utilized in patients that didn't tolerate ACE inhibitors. Theoretically, you could use an ARB in someone who had ACE inhibitor angioedema, but most patients or most physicians wouldn't use it unless there was a truly extraordinarily compelling reason for them to be on this class of medications. Tend to be more expensive than ACE inhibitors. So we prefer ACE inhibitors in general. And sort of the same sort of side effect sort of profile is that you want to be cautious when titrating them in patients with renal insufficiency and avoid in women of childbearing age. Vasodilators, so there's a variety that we use. Far and away, the most frequent one that we use would be hydralazine. We tend to hand out hydralazine like it's candy, but it certainly does have some side effects. And once you hit the higher doses, starting at like about 300 milligrams per day, your risk of developing severe side effects goes up, and you sort of hit a ceiling effect in terms of the blood pressure. So there's really no benefit to exceeding really probably closer to 200 milligrams per day, but 300 milligrams for sure. Minoxidil is a vasodilator that I certainly sort of think of as like a fifth line agent. It's extraordinarily potent, and if you have someone who has uncontrolled hypertension that you really just need to get controlled, I will certainly look to minoxidil. I did, unfortunately, I'm somewhat haunted by a patient that I had in fellowship where I didn't appreciate how potent minoxidil was and the need to titrate. And I ended up starting at essentially sort of half the maximum dose on a patient, and they developed profound hypotension, and it unfortunately led to bilateral watershed infarcts. And so that is certainly one of the drawbacks in over-aggressive sort of management of hypertension in our patient population is patients' cerebral autoregulation will be shifted due to their uncontrolled hypertension for the months to years that they were outpatients potentially. And so that may be one of the reasons why their blood pressure is so hard to control is their body sort of acclimated to that. And because of all of the side effects from minoxidil, we generally only sort of added in fourth, fifth line. And then nitroglycerin, nitroprusside, those are more continuous infusions. Things to know about it: nitroglycerin specifically is a pure venodilator, whereas nitroprusside is both an arterial and venous dilator. You can actually potentially worsen increased ICPs with these meds, so you should just be thoughtful with their use. Nitroprusside also with prolonged use can cause cyanide toxicity, which tends to be sort of either a dose dependent or a length dependent thing. And so I will use nipride as little as possible. The other thing to sort of know about these meds is you can have wide swings in blood pressure with relatively small dose adjustments. And so if at all possible, I usually try and use my nicardipine, and then we'll add in labetalol if I still can't do it, and then only sort of will use these meds if I'm absolutely forced into it. In terms, oops, this slide got messed up. But sort of the core diuretic classes are going to be your thiazide or thiazide-like diuretics, which are going to be hydrochlorothiazide, chlorthalidone, and then your loop diuretics, which we sort of use like candy as well in the ICU, your furosemide or Bumex. Reasons to sort of be cautious with thiazide-like diuretics is that they will frequently cause hyponatremia, and most of our patients were aiming for eunatremia, if not hypernatremia, for the cerebral edema sort of side effects. But sort of one of the things to just understand about hypertension is if you don't optimize someone's underlying volume status, their hypertension, it doesn't matter how much medication you sort of throw at them, like until they're euvolemic, you may not get the bang for the buck that you're hoping for with all of these different meds. So diuresis may be sort of very important. And obviously, you do have to be cautious with diuresis in terms of you can certainly precipitate acute kidney injury or acute kidney failure, particularly in patients that have underlying CKD. So alpha agonists, sort of the one that we tend to use more is the central alpha agonist clonidine. I like it in particular in patients that have any associated agitation or associated withdrawal symptoms, whether that's opiate withdrawal or alcohol withdrawal. We typically use BID or TID dosing and start low and titrate up. One of the nice things that that you can do in terms of and patients ensure compliance is that it can be converted to a patch after several weeks of use at a steady dose. But clonidine is, if you do have any sort of concerns about patients having issues with medication compliance, it is probably one of the worst medications in terms of causing a really severe rebound hypertension if there's abrupt withdrawal. So I always try and sort of be thoughtful about if I think that there will be any barriers to this patient being compliant with their medication therapy before sort of using that medicine. And then methyldopa is almost exclusively used in pregnancy. And then alpha blockers. I think we've sort of as a department started to use them more in terms of having so many patients with acute urinary retention and sort of trying to sort of tackle two problems with one stone. But terazosin I've started to use a lot. Things to know about initiating alpha blockers is there's not, I want to say it's in as many as 5% of patients that can have profound hypotension causing syncope after the very first dose. And then after subsequent doses, that risk dramatically decreases, though patients will frequently report ongoing issues with orthostasis. And it can also lead to some degree of reflex tachycardia and dizziness. And then phentolamine essentially would only be used in the context of like a pheochromocytoma or someone who had an amphetamine or cocaine overdose. And then you'll also see spironolactone used in some of our patients. This tends to be patients that have associated cirrhosis or are sort of really end stage CHF. And it's typically used in combination. So in general, when you're using antihypertensives, some of the most important things is just trying to understand, like particularly in patients that don't have a long-standing history of hypertension, is there anything like pain or agitation, hypoxia, or sort of iatrogenic hypervolemia due to 10 days of IV fluids that they maybe didn't need that you could address first? It's always easier to add medications than take them away, in that I would rather a patient get 5 PRNs overnight rather than end up with a secondary brain insult due to iatrogenic hypertension rather than boxing their kidneys. And even if that leaving them on a nicardipine drip for an extra day, I am always very thoughtful as I up titrate these medications. And then when you're starting meds, especially for our patients that we don't yet sort of know what trajectory they're on, maybe they are admitted with their CVA, but they also have this lingering or smoldering sepsis that hasn't yet sort of made itself known. We tend to prefer sort of starting with medications that have a shorter duration of action, in that if their blood pressure is going down, their heart rate's going down, you don't have to wait a full 24 hours for the effects to wear off. And I've hopefully sort of beaten this in to you, is that so many of these medications should be titrated upwards. So start low and work your way up. And then a lot of sort of medications that will be associated with, will be comorbid states with hypertension. So whether that's diabetes, CKD, history of MI, history of CHF, there will be sort of evidence-based medical therapies. So for example, a combination of beta blocker and ACE inhibitor is evidence-based in both history of MI and CHF. And technically, you're supposed to sort of document in the chart why any patients with those diagnoses are not getting those therapies. ACE inhibitors are also useful in the context of CKD, diabetes, patients with proteinuria. If someone has hyponatremia, I would be less likely to sort of jump to a thiazide diuretic. And then for whatever reason, Black Americans tend to respond very well to thiazide diuretics. So considering these other comorbidities when you're picking medications. Other sort of results I've seen is that sort of automatically assuming that because a patient has 4 antihypertensives listed and on their home med list, that they're actually taking those. So that home med list might be 4 years old, or or the reason that the patient had their ICH is that they haven't been on any blood pressure meds for the last year. And so it's certainly sort of one of those things before sort of starting all of their blood pressure medications at their like aggressive doses. It's probably worth specifically asking the patient if they've taken the medicine, or clarifying that with their pharmacy or their SNF or their loved one that lives with them before automatically starting them at their home doses. And then also note the timing of medication administration. A lot of times I will get called to see patients who are hypotensive at like between the hours of 10 and 11. And what will happen is that the patient will have like 4 antihypertensives that are all sort of given at that like between 7 and 8. And they'll all sort of hit the patient at once and lead to hypotension. And that may not be how they're actually taking them at home. So they might take 2 of those at night, or they might take their ACE inhibitor at noon with their other medications. So the default administration time that Epic will do may sort of lead to this iatrogenic hypotension. And then I, especially when I'm starting to add on 3rd, 4th, 5th antihypertensives, I will try and sort of maximize the doses of each of those meds before adding in additional medications, with the understanding that patients tend to be more likely to complain of side effects when they are using medications at the maximum doses. So sometimes a patient that's on a maximum dose of a single agent will complain of side effects, whereas if you add a 2nd dose and then use like half the max dose for both meds, they might be side effect free. And then also, as we're sort of adding all of these additional things on, you should sort of be thinking, do I need to be evaluating for possible secondary causes of hypertension? And as I sort of alluded to, there are other sort of secondary factors which could contribute to acute increases in blood pressure that may not actually require initiation of meds. So could they be withdrawing from alcohol? Maybe you didn't actually know that they had 3 antihypertensives that they're on at baseline, and they haven't gotten any of them because they're aphasic. They could be hypervolemic, just being in the postoperative or perioperative state. People are more likely to have like a surge of their catecholamines. And all of our patients with stroke, ICH, subarachnoid, etc., are just more likely to have high blood pressure. So in terms of sort of traversing some of these unique scenarios that we'll encounter in the ICU is when patients are NPO, when they're bradycardic and hypertensive, when they've gotten AKI and hypertension, and then when they're on a boatload of meds. So these are essentially sort of IV antihypertensives. We certainly will use our alazine and labetalol. Don't forget that enalaprilat is a nice option. Nicardipine is certainly our preferred agent. One thing that I'll certainly sort of comment on is that nicardipine, especially if it's not quote unquote max concentrated to the PIC or central line formulation, can result in a lot of IV fluids that are relatively unnecessary. So if someone needs to be on nicardipine for an extended period of time, please just work with your pharmacist to A, get a PIC line, and B, sort of max concentrate that. And then if your patient's sort of NPO and this isn't working, try and understand, like, if what's the holdup? Is it that they got TPA and you're sort of concerned about like dropping an NG tube or a Dobhoff? Maybe just wait 12 hours, or even sort of ask yourself, do I really need this strict of a blood pressure goal, or could I theoretically raise my goal? And then clovetapine is a pretty nice medication, but we don't actually have that here. And then esmolol we have, but it's so extraordinarily expensive that it's essentially only used for aortic dissection in our hospital. And so they've actually done sort of head-to-head studies in the neuro ICU, sort of looking for which medications are preferred. And I thought this was quite interesting. Essentially, in most cases, nicardipine is going to be the safest medication, and it tends to actually be better and more effective at blood pressure control. So if you know that a patient needs a drip and you're trying to figure out which one would be the preferred medicine, in general, go with your nicardipine. That's sort of reflected here as well. If though we ever get clovetapine, most people actually prefer clovetapine to nicardipine. So sometimes you may find yourself asked in terms of this patient's being admitted for elective surgery. What do I do with my blood pressure medications? And so certainly this is a decision that should be made in conjunction with anesthesia. But for the most part, sort of recommendations tend to be that if someone's on an alpha agonist, a beta blocker, a calcium channel blocker, or like a vasodilator like hydralazine, those are the meds that should be continued on the day of surgery, whereas diuretics and ACE inhibitors, ARBs, are ones that should be held. And so I don't generally sort of assist in this medication, so I don't want to tell you something that's different than what you typically do, but those are generally sort of what the guidelines suggest. And can anyone sort of weigh in with what you guys generally do?
We do what anesthesia tells us to do.
Fair enough. Okay. And if you do have perioperative hypertension, just make sure that oftentimes, like, just remember that our admission medication list is piss poor, frequently because the patient came intubated or altered or aphasic. And so just before you start like a nicardipine drip or all of those things, just try and check in and see, like, oh, do we actually have like an updated medication list? Because starting their home meds is the most simple, straightforward solution. And then address those other causes like pain, hypervolemia, etc. And then one thing that I have found happening to myself and others is, if I make the decision that I'm going to start a new blood pressure med, just make sure that when you're ordering it, and this is especially pertinent for the interns, is that oftentimes if you start it after 8 a.m., it will automatically default to tomorrow AM. And so just make sure that you're checking the little box that says admin time include now. And then in terms of perioperative beta blockers, this has been an ongoing area of evidence. There was a relatively recent Cochrane review. There are actually several recent Cochrane reviews And they ultimately sort of this said that it was the evidence is uncertain. You're going to have lower risk of AFib and MIs, but you're also going to increase the risk of bradycardia and hypotension. And it's not clear that it's an overall net benefit. Up to date ultimately says that they don't recommend sort of starting beta blocker therapy, but if someone's on it, they recommend avoiding sort of interruption of it. So if you end up with a patient who's bradycardic and hypertensive, and you've already addressed their pain, their agitation, their volume status, what are sort of safer meds in terms of treating them? So amlodipine, hydralazine, your ACE inhibitors and ARBs, your alpha blockers, and your aldosterone antagonists like spironolactone. These are all medications that shouldn't theoretically have a significant effect on someone's blood pressure, or rather heart rate. What if they have AKI and they're hypertensive? So if they have an AKI, first of all, sort of one of your jobs is to understand like why they have an AKI, in that just like patients that have chronic uncontrolled hypertension can have alterations of their cerebral autoregulation, same things happen to the kidneys. And so you can end up with relative renal hypoperfusion at these relatively normal blood pressures for the average person. That's sort of their kidneys are seeing sort of hypoperfusion. So you may actually be causing the AKI by having a blood pressure goal of SBP less than 140, as crazy as that sounds. You may be contributing to an AKI by having either hypovolemia or hypervolemia. So patients that have sort of cardiorenal syndrome, so meaning they have CKD and relatively end-stage CHF, a hypervolemic state may actually worsen their renal perfusion. So their volume status, either up or down, can lead to this. And then also, is the AKI due to the medication side effect? So in general, when you're initiating sort of an ACE inhibitor or an ARB therapy, in the average patient, you would expect to see an up to 20% increase in their serum creatinine, which will sort of be reflected as like a decrease in their GFR potentially. But if it's beyond that, I would have concerns that potentially they have hypovolemia, which is worsening it. Other patients who have renal artery stenosis, they are more likely to be to develop acute renal failure in the context of like initial sort of titrations of ACE inhibitors. So those should essentially be the things that you're considering, and basically just stop them. Maybe you started too high. Maybe there's something sort of intrinsically wrong with their kidneys. Just stop the ACE inhibitors, ARBs, and then also really sort of question, do I actually need any sort of Lasix in these patients, because hypovolemia will likely only exacerbate this problem. And then hypertensive despite multiple anti-hypertensive agents, certainly consider, do I need a secondary hypertension workup? So do I need a renal artery ultrasound with Dopplers? Do I need to make sure that they have CPAP for nights and naps? And then like your true zebras, like, do I need to check a 24-hour urinary meta, looking for wildly infrequent things like pheochromocytoma? And certainly I would hope that you guys would talk with us in terms of before you start going down those rabbit holes. And then sort of, as I mentioned, is your current medication regimen being optimized? Do you have like multiple different classes being utilized? Is a diuretic included in terms of just making sure that you're as close to euvolemia as possible? Are your medication doses optimized? So like I mentioned, are the patients even getting it because their co-reg is so high that they've been bradycardic into the 50s, and so the nurses are holding their max dose co-reg? Is your patient absorbing the medication? So one of the things that we'll see is critically ill patients can have like impaired sort of gastric absorption. or they might have an ileus, so they're essentially not absorbing the meds, and then they might like sort of absorb them all at once and develop hypotension. And then maybe the patient's getting so many PRNs with labetalol that they're bradycardic secondary to that, so that they're not actually getting their scheduled co-reg. And then if you truly are using like 4, 5, 6 antihypertensives, it may be reasonable to touch base with nephrology. Other things that I always like to be thoughtful about, even though I'm seeing patients in the context of critical illness, I always like to be thinking about like what are sort of the next steps. So having them on like Q4 nifedipine is not like going to be a winning sort of strategy for controlling their blood pressure at home. So understanding, should I be switching their meds to something that's actually something that they can be compliant with? And also, even though sort of your big concern when you're discharging patients might be something along the lines of setting up their neurosurgery follow-up, it's just as important, especially if you started a patient on a bunch of new meds, to ensure that they have close PCP follow-up, and that these patients can have evolving sort of heart rates, blood pressures, renal functions, and they'll frequently need like a vitals check as well as labs to look at their potassium, their sodium, and their BU and creatinine, particularly if they've been having relatively low blood pressures, which could cause renal hypoperfusion and an AKI, or our patients are prone to developing hyponatremia, and certainly checking on those things. And a lot of our patients are going to need to have frequent sort of titrations, and maybe even having several of their blood pressure meds like peeled off as they get further out from their acute stroke or acute hemorrhage. And so what are some of the strategies that you can employ to encourage compliance with the medication regimen after discharge? First and foremost, you just need to make sure that patients can actually afford their medications. One of the things that I try and think about is health literacy. So a lot of our patients came in and they weren't on their blood pressure meds that they had been prescribed. So what was the thing that sort of prevented them from being compliant? Was it a finances thing? Was it a fact that they didn't understand the importance of it? Because even though they have, they're walking around with a blood pressure of 200, they feel great. Is it that they think that they would have to feel sick in order to require treatment for hypertension? Or maybe are they having side effects? They can't sleep and make it to their job on time because they're waking up 5 times in the middle of the night to pee, or they're having incontinence, and that's not acceptable to them because of the diuretic side effects. So really trying to understand those things is maybe like one of the most important things that we do in terms of preventing them from actually bouncing back with their second hemorrhage due to uncontrolled blood pressure. And then also, like I sort of mentioned, if someone who's going home to a SNF or being discharged to a SNF or an LTAC, you might be able to get away with those QID dosages, whereas someone who's going home and is hopefully going back to work, like optimizing like the clonidine patch or amlodipine, which has once daily administration, or lisinopril, which is again typically once daily, that might be sort of beneficial, and also looking at your extended release formulations. What are some options for patients who can't afford their medications? Walmart, Target, Costco, Kroger, Sam's Club, these are all organizations that have, like, it's called the $4 list, whether or not the prices are actually exactly $4. But there are lots of different options that you can potentially help patients with. There's also something called the Good RX card, which is, it's a no cost thing. You essentially can give the patients this, and they can present it to a pharmacy and may actually be able to get lower prices than even what their insurance would otherwise ask them to pay. There are things like manufacturer discounts for a lot of the newer sort of antiplatelet or anticoagulant medications that we use. And then I think it's really important that you make sure that the patients sort of feel comfortable. You don't automatically assume that a patient can afford that. And we have very sort of different financial situations than some of our patients may. And it doesn't matter if you have a patient on first line evidence-based medication. If it's too expensive for them and they don't take it, then the second line, even if it's a distant second in terms of effectiveness, that if they're actually able to afford that and take it, that's ultimately going to be the better decision for patients. So just to give you an idea of some of the sort of cardiac anticoagulant meds that Walmart has, and even things like Plavix, though it's more expensive than $4, that this is certainly a more affordable option than a lot of other pharmacies. I think technically Wisconsin prices had a little asterisk that it could be a little bit more expensive. I'm just going to sort of jump over this, but just so you know, there were sort of new guidelines that came out from the International Society of Hypertension in the last couple of months, and they sort of talk about things that are optimal versus mandatory. But essentially, one important point is that in general, we tend to have a stricter blood pressure threshold for younger patients, and that lower blood pressures for older folks are more likely to sort of be associated with orthostatic hypotension and falls, as well as renal complications. And so this is kind of talking about this, but I thought it was interesting that they recommended sort of low dose combination therapies as sort of first line, and that usually most people would traditionally select a single agent. So this is kind of the same thing. So AFib is another sort of huge thing that we deal with in the ICU. We don't always have the benefit of understanding if this is like truly new onset versus paroxysmal AFib that we are just capturing now because the patient's an inpatient. But it has a huge range in terms of being reported anywhere from 5 to 46% of critically ill patients. And it's a big deal because it's associated with significant morbidity and mortality, which I'll go into in more detail in the next slide. And quite honestly, there's not a lot of great high quality evidence on how to manage this in patients, and that most of the research has been done in the outpatient sphere. And so we sort of are extrapolating sort of our outpatient evidence to our critically ill patients, which certainly has issues. In terms of these risk factors that make people at risk for developing new onset AFib, in my opinion, sort of the most important would be fluid overload, hypoxia, hypotension, or hypovolemia, certainly electrolyte abnormalities, and just know that it's going to be more common in really sick patients. So as well as shock from all causes, sepsis or SIRS, heart failure with pulmonary edema, any sort of structural cardiac issue, whether that's ischemic heart disease, an MI. And then so many of the vasopressors that we use have beta activity, which sort of predispose evolution into arrhythmias. So associated with both increased morbidity and mortality, in that patients that have new onset AFib in the hospital are more likely to have in-hospital strokes, have a higher risk of stroke in the subsequent 5 years, and then be more likely to be hospitalized again for heart failure. And though we oftentimes sort of our goal when someone develops AFib will be to sort of get them back into normal sinus rhythm, that's not always sort of an achievable goal. And up to 1 in 5 patients will actually leave the ICU still in AFib, though it may be rate controlled AFib. And I sort of like nervous in terms of sharing this mortality data with you, in that it's not necessarily that patients, there's not necessarily a causal relationship in terms of increased mortality with those who develop new onset AFib, in that it's likely that new onset AFib is a marker of disease severity. But I do think it's sort of worth understanding that having new onset AFib in hospital has been shown to sort of increase mortality 2 to 3 times in various sort of critically ill patients, both in the medical sphere as well as the the surgical sphere. So how do you sort of manage this? Well, first and foremost, you want to address any of the modifiable risk factors. So treat those underlying electrolyte abnormalities. We talk about sort of the cardiac sort of thresholds for your potassiums greater than 4, mags greater than 2, and phos is anywhere from 2.5 to greater than 3. If they're hypoxic or they've got a metabolic acidosis, or rather a respiratory acidosis, treat that hypercapnia, address their volume status. So many of our patients, we are inclined to give them IV fluids, but to be honest, in my opinion, more often than not, we have patients that are hypervolemic, and so that their atria are being stretched by that extra blood volume, and so actually diuresis is going to be effective. One thing that I think is important in terms of just talking to nurses about is if you diurese them is you're going to want them to recheck their K and their mag after getting those diuretics. And if someone has both hypokalemia and hypomagnesemia, in my opinion, it's more important to treat or replete the magnesium first, and that your body needs appropriate levels of magnesium in order to hold on to K. So if they are giving the K before they're giving the mag supplementation, in some ways you're like throwing it just in the garbage. So just sort of telling the nurses sort of like that you specifically are hoping that they'll replete their mag before their K can sort of be very helpful. And then also treat the underlying issue. So one of the reasons why AFib in the ICU is so challenging to control is that there are underlying drivers, whether that's sepsis, cardiac ischemia, adrenergic overstimulation, whether that's someone who's withdrawing from alcohol or whatnot. You won't be able to control the AFib with RVR until you treat the underlying cause. And even if you do convert them back to normal sinus rhythm, odds are they'll pop back into AFib. And so it can be a challenge to control. If they're hemodynamically unstable, one of the first things that you have to try and understand is the hypotension because of the AFib, or did they develop hypotension and they were sort of popped into AFib with RVR as sort of a compensatory mechanism? And sort of trying to talk with the nurse and understand the timing of, did the hypotension or the AFib, like which order did they happen in? And you may not always sort of have the benefit of understanding that, but if someone is truly in hypotension as a result of AFib with RVR, truly sort of the treatment of choice would be a synchronized cardioversion. I oftentimes am hesitant to do that in the ICU though, because you have to sedate patients. There's a risk of sort of RNT phenomenon and sort of causing VFib. And you have to sedate with meds, and there's those other things, patients can aspirate, etc. And it's just not nearly as durable in the critically ill patients. So cardioversion of patients seen in clinic or in the ED who present with AFib with RVR, you have a 90% conversion rate, whereas it's only 35% conversion rate in the ICU. And of that 35%, most of the patients will revert back to AFib within 48 hours. So it's frustrating to do all of that work and sort of put the patient through the risk of a cardioversion just to have them pop back in an hour later. But ultimately, a lot of the decision comes down to, are you going to rate control them or are you going to rhythm control them? And so rate control typically suggests that in general, the heart rate is below 110. And our first line meds are going to be metoprolol or diltiazem. If you have AFib with RVR, obviously we're going to prefer IV meds to PO meds. But as soon as you do have them rate controlled, you're going to want to go ahead and follow up that IV dose with regularly scheduled PO doses, and you're going to want to give don't use the extended release formulations. You're going to use the immediate doses, and I prefer sort of doing it on a Q6 dosing regimen. So which is different and distinct from a QID in that if you do a QID, they're going to sort of stack the doses during the daytime hours and then usually have an 8-hour period where they're not getting the meds, and that overnight period is where patients will frequently pop back into AFib. So the specifically picking a Q6 dosing regimen is preferred. Beta blockers certainly can worsen things in the context of uncompensated heart failure, and I'm very cautious about using these calcium channel blockers in patients with low EF below 45%. DIG we always talk about, but it's essentially is worthless, and that takes at least 6 hours to be effective. But if someone has CHF, you can certainly try it. Magnesium sulfate, just giving someone anywhere from 2 to 4 grams of IV mag can be effective by itself in terms of converting to normal sinus rhythm, and it's also very synergistic when given with amiodarone. So, and you want to give the mag before you give the amio. And then in general, rate control tends to be the better option for critically ill patients because a lot of these people are going to spontaneously convert to normal sinus rhythm as the sort of acute illness sort of resolves. And then amio has a better side effect profile than pretty much any other antiarrhythmic. The conversion time can be long, so don't expect magic after you give that 150 milligram bolus. And even if you have someone on an amio drip for a day or two, it can easily take over 3 days before you see sort of a cardioversion. And these prolonged sort of periods of AFib predispose patients to developing intracardiac thrombi, which then can lead to stroke and things like that. So it's certainly sort of a complicated problem to have. If you were to cardiovert someone after a prolonged bout of AFib, ideally we would start them on anticoagulation, though obviously in the neurosurgery ICU, there's a lot of patients where we don't necessarily do that. But I do think some of our patients, we just sort of like forget that. There are certainly patients that we see where there would not necessarily be a contraindication to anticoagulation. So that's certainly something that you should always sort of keep in the back of your mind. And then this just sort of talks about it. Correct those modifiable risk factors, correct the electrolytes, try a bolus of magnesium. If that doesn't work, I would attempt rate control with either beta blockers or calcium channel blockers. If that's not effective, then I would probably switch to an antiarrhythmic approach. And if at any point they're hemodynamically unstable, consider synchronized cardioversion. And then also always sort of ask yourself, do they have a good indication for anticoagulation? And is there any reason why I couldn't anticoagulate them? So that's it. Any questions at all?
Darcy, thought it was really helpful. Thanks a lot.
Okay, well, sounds good. We're always happy to see these patients. I don't want to make it sound like we're not, but I do just want to make sure that you're always sort of thoughtful about slowly up titrating them and clarifying patients what their home meds are and if they're actually taking them as prescribed before you just automatically reorder them. Okay, bye guys, take care.
Thanks, Marie, and another great talk.